and welcome back to my channel. If this is your first time here, I'm Nurse Alyssa, and today we're going to be doing another case study. So today's case study is a diabetic foot ulcer. So we're going to be using different assessment tools, different flow charts. They can all be found in my wound assessment dressing selection tool. If you are interested in this, I'll link it up above here. You can get it on Amazon. Once again, I'll put it in the description too. But I am going to show you the actual assessment that is found in this book and the actual flow chart that are in this book of exactly how we use them to determine the dressing choice for this case study, okay? So I'm going to be doing a lot of these case studies on my channel now, and we use this book every single time. We use the flow charts in it. This book has all the tools that I'm going to be using in these case studies to determine the dressing and appropriate best practice guidelines, okay? So let's get started. So I do just want to put a disclaimer that these are not real patients. They may be based on real patients, but name, age, gender, they are not connected. They're just made up scenarios, okay? So case study, diabetic foot ulcer. Patient's name is Robert Lee. His age is 54, male. Medical history, type 2 diabetes. He has been diagnosed for 10 years. He has peripheral neuropathy, so he doesn't have a very good feeling in his feet. He has hypertension, so high blood pressure and high cholesterol. Under lifestyle, he is a non-smoker, lives a stationary lifestyle, and his diet is poor with high carbohydrate intake. So how does Robert present? So his chief complaint when he comes in is he presents with a painful ulcer on the plantar aspect of his right foot, so the very bottom of his foot, as you can see in the picture here. Now, he first noticed this 3 weeks ago after experiencing increased numbness and tingling in his toes, and he says that it has been getting worse. The wound characteristic, so it's on the plantar surface of the right foot. It is 3 by 4 centimeters. The appearance, it's well defined with a sloughy wound base, and it is surrounded with a callus. Now you'll notice with a lot of diabetic foot ulcers, there is a callus surrounding the ulcer. It's because it's a high friction area. That's why it's super important that diabetics do wear diabetic footwear, just to prevent ulcers from happening. Now, we can't prevent all of them, but if we can do whatever we can to try to prevent them, that's what we try to do. So I do have a link down below for diabetic footwear, so I will put a link there. There is no exudate, and the pain is a moderate 5 out of 10. And it does get worse on activity. So physical assessment, there is a reduction in sensation in the feet. So I did test his feet using a monofilament and a tuning fork for vibration perception. And it did show a reduce in sensation in the feet, which does show the peripheral neuropathy. There is slight redness around the ulcer with no sign of drainage at all. It is a sloughy wound base with a very foul odor. And the pedal pulses, they're weak, but you can feel them. Diabetic control, so his hemoglobin A1C was tested, and that gives a range of the blood sugar over the last 3 months, and it was an 8.2, so that does indicate poor glycemic control. And his social assessment, he lives with his family, but has had difficulty managing dietary habits and foot care. So his diagnosis is a diabetic foot ulcer secondary to peripheral neuropathy and poor glycemic control. So now I'm going to go over my actual assessment of how I would put this into my chart. Once again, it's in this book, my actual wound assessment that I use when assessing a wound. So as you can see here, the type of wound, so it has all the different types of wounds. Checked off is the diabetic foot ulcer. Now, if you read next to it, it says reduce pressure, offload, debride any calluses, and infection management. So for all these wounds here next to it, it does say what you need to be doing. And once again, that is in the book here. This exactly what you're seeing is right out of the book. The type of wound is a maintenance wound, and the drainage type and drainage amount there is no drainage, but there is a strong foul odor. So that is marked off. Now, under infection here, so we do have two sides to the chart, and I do just like to explain this. So it's called NERDs and stonies. So NERDs shows local infection, and stonies shows a more deep spreading infection. So for local infections, a topical antimicrobial is suffice. For deep spreading infection, you need to have an antibiotic ordered for the patient. So here I have check marked off everything that we're seeing. So it's a non-healing wound. It's kind of getting worse. There is slough in the wound base. It has a foul odor. The patient said that it's been getting worse, so new breakdown. There is redness around the wound, and once again, smell. So as you can see here, there is 3 on each side. Now, there doesn't have to be 3 on each side. It could be 3 on either side, but here there's 3 on both sides. We're going to go with, obviously, the stronger of the one. It's obviously a spreading infection here. So we would need to have an antibiotic ordered. So either you would talk to the doctor or send them a fax if you're working in home and community. I do want to note that you would also use a topical antimicrobial during this time also. So the pain is 5 out of 10. And then the peri-wound area, it was dry, intact, and then there was that callus around the whole wound. Now, with diabetic foot ulcers, like I said, there is a lot of time calluses on the feet. These do need to be shaved down. Now, I do not recommend at all for any patients to be doing this, and it should be done by a foot care nurse or wound care specialist or doctor. Any of them can do it, but it should be a trained professional, especially when it's around a wound. So to get the wound actually closed, we do have to kind of shave off that calloused area to soft tissue. We don't want to go down to bleeding tissue. We just want to go down to nice soft tissue. Next, we look at the wound base. So we do have that slough material in the wound base. So that's the assessment. Now we're going to get into more details, okay? So wound care, just like any wound, we're going to cleanse it with saline and remove any debris from the wound. So that's how we always start. Now, sometimes we do use other solutions such as a Vashi wash solution, iodine solution, chlorhexidine. But in most cases, we just use a saline rinse. And then in the case of having slough or necrotic tissue, you're going to have a sterile gauze and you're going to moisten it with saline and try to wipe some of that sloughy material out. So as you can see off to the side here, under the types of wounds again, we want to remember we need to reduce pressure / offload, debride any calluses, and infection management. So if you're not trained or you are a patient and you have a diabetic foot ulcer, have a trained professional take care of that callus. We need to take care of that callus, and we also need to reduce pressure to the area. So there is special offloading shoes that a patient could wear. So it's completely up to your doctor and wound care specialist of how you go about that. There is also total contact casting, which is best practice for diabetic foot ulcers, but it will only ever be used once for a patient, at least here where I'm located. That's kind of the rules because it is very expensive to do for patients. So it's kind of, we'll do it one time until the diabetic foot ulcer is healed. But if they have it again, it's not something that the patient would get again. And the total contact casting, it is used to offload the area of the foot so the pressure isn't going on that wound. That's the main goal. And once again, there's lots of different shoes that you can get to offload. So as you've seen in the picture earlier, the wound was right by the toes. So we would offload the front of the foot. So it would be an offloading shoe that would really just have the back of the shoe and where you're stepping on the back and not the front. So now we're going to go into the actual dressing choices and how we're going to decide what dressing we're going to use for this diabetic foot ulcer. Now, once again, all the flow charts can be found in this book. So you're seeing the chart here right out of the book. We have a dry wound, so we can have a hydrogel, film, acrylic, or non-adherent contact layer. Now, not all of these, as you will see further in a few more slides here, not all of them will work for this patient because we have to take all the information, put it together, and see what works. So I will take every part of each flow chart and put it onto a separate slide so you can see how we actually come up with the exact dressing we're going to use. Next flowchart shows the clinical situation. So do we have epithelial or granulation tissue, or do we have slough or necrotic tissue? So we are having that slough in the wound base. Now, I did categorize this as a maintenance wound. It is a maintenance wound, but it is healable. So I wouldn't categorize it as non-healable. They have diabetes, so there's an outside factor that's slowing down the healing process. So it is still a healable wound though. So we see the slough and healable wound. So we go right here. So what are we going to do? We're going to debride, accept dry, stable eschar on heels, and prevent infection and moisture balance, okay? And then we have all the dressings here. So acrylic, calcium alginate, film, membrane, foam, gauze, gelling fiber, hydrocolloid, hydrogel, and hydrophilic dressing. Now, once again, not all of these will be appropriate, but we will take this and put it on to another slide. Our next flow chart here shows the different clinical situations that could be happening. So maceration or excoriation, we don't have. Infection, wound pain, we do have, and we don't have tunneling or undermining. So we just kind of omit what we don't need, take what we do. So once again, we will take this and put it on our next slide. So let's move forward onto our next slide here. As you can see, I've taken everything that pertains to our specific wound, and I've placed it here. So we have a dry wound, so we can have a hydrogel, a film, acrylic, or non-adherent contact layer. Okay, perfect. And now we will match our dry dressings with the rest here. So once again, for slough, we can have an acrylic. They match. We always want to match it off this top one because that controls our moisture, and we always want to have a moisture balanced wound. The wound needs to be as moist as our eyeball. Okay, that allows perfect conditions to heal. So we have acrylic, film, membrane. Okay, so it matches. The calcium alginate, it's not up here. That's too strong, so we wouldn't use that. It absorbs way too much, and it would dry out the wound even more. Foam, can't use. Gauze, can't use. Gelling fiber, can't use because it's not one of these up here. Hydrocolloid, can't use because it's not up here. Hydrogel, we can use, okay? Hydrophilic dressing, once again, not up here, so we're not going to use. So we have stars next to three possible dressings that we can use to help debride the slough, okay? Because that's what we're using these dressings for. So we take all the information that we've received from the wound assessment and we plug it into these charts, okay? So we need something for the dryness, for the slough, for the infection, okay? And then there is also pain, but we would, that doesn't go with the dressing, and we would just talk to them about using an over-the-counter medication, and if that's not strong enough, they would need to talk to their doctor. So we do have all the possible dressing choices here, just for your basic. Now, this is basic nursing wound care, okay? This isn't specialized. This isn't absolutely everything that we can use. There's a lot of clinical judgment, and when it comes to wound care specialists, we have a lot more in our toolboxes that we can use, but we always start with the basics. So for your normal nurse, or if you're a patient, these work absolutely amazing. But when it gets into the a lot more complicated cases, this still does work. But once again, it doesn't have like your Vashi wash or your Prisma. There's dressings, the more specialty dressings, they're not in these charts, okay? So this is your normal nursing wound care. And a lot of doctors just go off this. And then if wounds are not improving, they may be sent to a wound care specialist for more specialized dress. So then we're going to look at the final piece of the chart here, which is infection. So what we want to do is reduce bacterial burden. Now the patient obviously does have a deep spreading infection. They'll be on an antibiotic for this. Normally we take a wound culture because we don't just want to be throwing antibiotics at them. We want to do a culture and sensitivity to make sure that we're using the best possible antibiotic to knock out that bacteria. But for our topical antimicrobial that we're going to be using, so we have gentian violet and methylene blue, honey, iodine, PHMB, silver, and a hypertonic dressing. Now, because this is a dry wound, okay, I see here hydrogels, okay, so that adds moisture. Out of all of these, what's going to add moisture to the wound is the honey. Iodine kind of dries out the wound. We're just looking at all of them and knowing what's available for a dry wound. Honey is really our best option, especially with slough. So the Meta Honey, it actually debrides also. So you have to think about everything that's going on. What do you need for this wound? You need to correct the dryness, you need to correct the slough, and you need to correct the infection. So the honey is the one that is going to add moisture, provide autolytic debridement, and help fight against the bacteria. So we would use the honey and an appropriate cover dressing. So for the cover dress, you can use a silicone with an adhesive border. That's what most people really like to cover their chronic wounds. I have found leave-in to be a great one. It does provide a little bit of cushion, and that does help with offloading of the foot also. But really, any cover dressing would be appropriate as long as it doesn't absorb too much, okay? You don't want it to just be absorbing, because we are adding that honey. So we can add moisture and we just don't want to be sucking it away. We want to make sure that we are keeping the wound, that eyeball moist. So it really is a balancing act, and you have to use your clinical judgment to determine what you're going to put on that wound as a cover dressing, but we are going to use honey. So as you can see here, this would be our dressing choices. So we have the Meta Honey, and then I did put here as a cover dressing, so your silicone foam dressing or your island dressing. Now you kind of just have to go based off how the wound is looking. So if you use the foam, if it still seems dry, which it really shouldn't, because the honey for the most part does stay in place and does hydrate the wound. So as long as it's not drying out with this, it's absolutely fine. Or you can use the island dressing. So really you're just using the cover dressing that you feel is most appropriate for the wound, but we're hydrating the wound with the Meta Honey already, because that's really covering everything that we need for the dryness, the slough, and the infection. And then we just need to put a cover dressing over top of that. Now we're going to look at infection control. So we do need to monitor for signs of infection, which we already do have. So we do want to make sure once the patient is on antibiotics that we do see improvement. For pain management, so the patient did say that they had a 5 out of 10 pain, so we do want to make sure that they are aware that they can use over-the-counter medications. And if that's not cutting it, if Tylenol, Advil is not cutting the pain, then they would need to seek their doctor and see if they can get something a little bit stronger to help for the pain. Now, we do want to look at the patient as a whole and not just a hole in the patient. That's why when we're doing our assessment, we look at so many different aspects and not just the wound. So this is really when it comes into factor here, because we were looking at how the patient has diabetes and it is not controlled very well, as we could tell by the hemoglobin A1C. So we do want to refer the patient to a diabetes educator to help Robert better understand and manage his diabetes and his diet. Under patient education, so we want to educate Robert on daily foot care practices, including inspection for injuries, proper footwear, and maintaining foot hygiene. So we want to make sure that diabetic patients are looking at their feet twice a day, once in the morning, once at night. And before they put on their shoes for the day, you want to stick your hand inside the shoe, shake the shoe out, make sure there's no rocks in there, no Legos in there. A kid, I have seen kids put things in shoes before, and then it just kind of rubs and eats away at the foot all day. Now, if you don't have diabetes, you're like, oh, that's wild, but it happens because they don't have that sensation when you have peripheral neuropathy. You don't have the same sensation in the feet, or you don't have any sensation at all. So sometimes it goes unnoticed for an entire day, and then there is a huge ulcer on the foot at the end of the day. So always make sure to check the feet before and after, and check the shoes inside and out to make sure there's no nails, tacks, anything that could be sticking into the shoe. Now, follow up, we do want to follow up within 1 week of this new dressing for this patient, just to make sure that it is working well, and that there's no issues with maceration. There shouldn't be with dry wounds when you add moisture to them. They most of the time don't get too wet. But if you do have maceration, you may need to go to a different dressing. But for the sakes of this case study, it's a dry wound. Meta-honey is absolutely acceptable, and I've used it for moderate exudating, which is absolutely fine. Sometimes we do just have to protect the peri-wound with a skin protectant. So kind of a summary here. So the wound care, we want to clean, debride, and apply an appropriate dressing. We want to offload, so have offloading shoes or boots. Glycemic control, so we want to refer to a diabetic educator. Pain management, we want to make sure that they can use over-the-counter pain medications, or they need to talk to the doctor if that's not working. Infection monitoring, so we just want to keep an eye on the infection, keep using our NERDS and Stoney's chart, and make sure that the patient does talk to the doctor, or you talk to the doctor, send a fax, whatever you have to do, whatever the protocol is for your facility of how to contact the doctor to ensure that the patient is placed on an antibiotic and a wound culture is taken, as that is best practice. Patient education, we want to make sure that we're teaching proper foot care and dietary changes. Now, if Robert adheres to best practice treatment and lifestyle modifications, he does have the potential for significant improvement in this diabetic foot ulcer. He will need ongoing education, regular follow-ups, and to be monitored closely. A lot of times with diabetic foot ulcers, they can turn into bone infections. So we got to be very, very cautious, especially when somebody does have an infection. We want to make sure we get that culture right away, get them on an antibiotic. So I hope you did find this video helpful and the charts helpful. You do have to use some clinical judgment with them. It's providing you all the information you need. It has everything there, but the final decision is using clinical judgment, especially for, say, the honey that we use today. We had to use clinical judgment, like, okay, that's going to hydrate, so that's our best choice as an antimicrobial for this. So we look at all the options that we have available of what we can use. It really narrows it down. There's so many different wound care products, and these charts really narrow it down and allow us to pick our dressing from there. Okay, so I'll keep doing these so it keeps helping reinforce how to pick a dressing, and I'm going to try to put out one of these videos every Wednesday. I really hope it does help. Let me know down in the comments if you have a certain scenario. I can't do specific cases, but I can do case scenarios based off of real situations. So if you have one of those, you can feel free to email me to asknursealyssa@gmail.com. I'll put that down in the description. If you have a certain case that you just kind of want to know about, give me some information. If I don't have enough information, I'll just kind of make it up along the way. And make a case study like I have here. But if it's a certain type of wound, a certain type of drainage, if there's infection, give me some information about the wound of what you would like to see, and I can definitely make one based off of that. Okay, guys? So I hope you did find this helpful. If you are looking for these charts, once again, it is in this book. I'll link it here. And I hope you guys have a wonderful day. See you guys next time.